Dr. Shah.
Good afternoon.
Hi, Dr. Shah. One question. Where can we find these slides?
These are all posted on Canvas. That will be week 12.
Looking.
Yeah, all of these have already been posted a while ago with and without answers. Right? It is a clinical case on cardiac electrophysiology. So there were 3 interactive sessions in week 12, right? So it is posted separately under week 12.
Found them. Thank you.
Thank you. Sure. All right, so let's get started. Good afternoon, everybody. Welcome to our clinical cardiology or electrophysiology session. We will talk about hyper and hypokalemia and how that will alter the excitability of the excitable cell, mainly cardiac myocyte and SA nodal cells. Okay, so we will talk about that. There is a clinical case written based on my own experience. So it's a real life example where a patient who is having a myocardial infarction will develop hyperkalemia, and how that hyperkalemia will basically result in different clinical consequences or problem. All right. So who can read the case for me? So we'll go from there. Yeah, Andrew, go ahead.
Oh, thank you, doctor. So, for this case, a 64-year-old man suddenly felt a crushing pain beneath his sternum. He became weak and began to sweat profusely. He called his physician, who advised him to go to the hospital immediately by ambulance. The tests made at the hospital confirmed his physician's belief that the patient had suffered a heart attack, that is, a major coronary artery had suddenly become occluded. So, do you want me to read the rest of it?
Yeah, please go ahead.
Okay, thank you. When a coronary artery is occluded, the potassium concentration rises in the interstitial fluid of the ischemic region, the region deprived of its body supply, of the ventricular myocardium. What effect does the elevated potassium concentration in the interstitial fluid have on the resting membrane potential of myocardial cells in the ischemic zone? What effect does the change in resting membrane potential have on the propagation of the cardiac impulse, and why? And why might such a change in impulse propagation lead to reentrant rhythmic disturbances?
Excellent. So let's talk about that. You all have this. I have posted this case a while ago. You all have access to this case, and Andrew is kind enough for us to read the stem or stem of this clinical case, and there are 3 questions for this clinical case that we will discuss first before we discuss other questions. So and you learned about hyperkalemia in the past. So tell me, let's get to the first question. It's a case of myocardial infarction, and the potassium will be released from the dead myocardial cells into the extracellular fluid or ECF compartment, and which will result in hyperkalemia. So how that hyperkalemia will alter the excitability of the excitable cell, here cardiac myocyte, and how that will change the resting membrane potential. What is the effect of hyperkalemia on resting membrane potential? First of all, tell me what is resting membrane potential. Why resting membrane potential is negative in cardiac myocyte or in SA node. In cardiac myocyte, the resting membrane potential, as we discussed yesterday is around minus 90 millivolt. In sinoatrial node, the resting membrane potential is around minus 60 millivolt. So why the resting membrane potential is negative? Even resting membrane potential is negative also in nerve, in neuron, or in skeletal muscle. So why the resting membrane potential is negative? What makes it negative? Yes, Andrew.
Oh, thank you. Doesn't it want to be around the equilibrium potential of the potassium in the cell?
Yes, why?
All right. To keep it resting. Sure.
You're right. It is very, especially in cardiac myocyte, the resting membrane potential is very close to potassium equilibrium potential. You are correct. Why the resting membrane potential is negative, or why it is close to potassium equilibrium potential in cardiac myocyte? Yes, Sadaf.
Is it because that so sodium channels are closed and calcium was open during repolarization, so we got so many calcium and the cell become negative. So on the graph, the curve goes very low, I believe.
Anybody else wants to say? This is very fundamental question. Can you please all turn on your camera, because I am not enjoying teaching it. It's very important case there we are going to discuss today. It's very important, and I want to break it down in a small pieces so you can easily understand. It is very important for the first year DO students, especially because they will be in second year up, next year, and they would have to know all of this before they learn any cardiac electrophysiology and EKG and abnormal EKG, EKG abnormalities. So it is very important, and hyper and hypokalemia are one of the common clinical presentation in clinical settings, which is very difficult to diagnose, because both hyperkalemia and hypokalemia, the clinical manifestations which are exhibited by a patient, they are almost the same clinical presentation. They exhibit same clinical manifestations. So it is very difficult to diagnose hyper and hypokalemia clinically. You can only diagnose a hyper and hypokalemia clinically easily is by looking at electrocardiogram, EKG, which is one of the a critical tool to diagnose hyper and hypokalemia instantly, quickly. The second part or second investigation that we use to measure or to diagnose hypokalemia is the lab. We quantify the level of potassium in blood. Take a look at the level of potassium in blood, and that will take some time. And by that time, our blood results come for the potassium, patient may die. So the best tool to diagnose hyper and hypokalemia clinically is cardiac electrogram. Okay, electrocardiogram or cardiac electrogram, EKG or ECG, that you have to use that as a tool to diagnose hyper and hypokalemia. Because if you take a blood sample and if you want to quantify the level of potassium, it may take some time to get the result. And if you want to diagnose the patient who is having a hyper and hypokalemia, they are almost presenting with similar clinical manifestations. So it is very difficult to diagnose hyper or hypokalemia clinically, because they both exhibit in the same form, in the same clinical manifestations. Okay, very important. So that's why it is clinically important. Why resting membrane potential is negative? Very simple question. Yes, Jasmine.
Is it because there's just more potassium ions within the cell, so the cell is going to be closer to potassium's equilibrium potential?
Say that again.
I said because there's more potassium ions within the cells, so the cell's membrane potential is going to be closer to potassium's equilibrium potential.
Yeah, you're right, but why? My question is that you are correct. All right. So what is the potassium concentration in the ICF, and what is the potassium concentration in ECF? Who can answer that? Remember, 98% of potassium is stored in ICF. only 2% of potassium is stored in ECF. Very small amount of potassium is located in the extracellular fluid compartment. Most of the potassium is situated in intracellular fluid compartment, which is 98%. 98% of potassium is situated in intracellular fluid compartment. Only 2% of potassium is located in extracellular fluid compartment. Now, 98% potassium is equal to approximately in the range of 130 millimoles to 150 milli equivalents or millimoles per liter. So inside the cell, you have 130 to 150 millimoles or milli equivalents per liter of potassium located inside the cell. In ECF, it is only 3.5 to 5 milli equivalents per liter of potassium. So outside, the level of potassium is very small compared to inside potassium. Now, because of that, what would happen? This is very fundamental questions. I mean, before I really get to the difficult part, I really want to make sure that you all of are aware about that what is the major contributor that will create or establish and maintain the resting membrane potential at minus 90 millivolt in cardiac myocyte and minus 60 millivolt in SA node. Or generally speaking, it is negative because of what?
Can I answer, Dr. Shah?
Yeah, please.
Okay, I think it's because of the potassium leaking channel. So the potassium leaves the cell more. It makes the inside of the cell more positive. So we get more negative charges on the inside rather than the outside. The potassium takes the positive charge outside with it.
Excellent. Very good. Why?
Hmm.
Why potassium keeps leaving? You said
Because
that
of the leak channels.
leak channels, but why it keeps leaving? I just said that earlier.
Yeah, because it wants to be outside.
Hi, Dr. Shah.
Yes.
Because the electrical gradient.
Very good. Because of very good, good job. Because of electrochemical gradient. So there is a high concentration of potassium inside the cell, as I told you earlier, and there is a very low potassium outside. So obviously, inside is negative with respect to outside. So there is a large electrochemical gradient for potassium to leave the cell down its electrochemical gradient from ICF to ECF. Okay, through the ungated or leak potassium channel, as Sadaf said. So potassium keeps leaving, and potassium is a cation. So since potassium keeps leaving, it will drive is resting membrane potential towards more its potassium equilibrium potential, which is minus 85 to minus 95 millivolt. That's why the resting membrane potential is negative, because the potassium keeps leaving through ungated or leaked potassium channel down its electrochemical gradient from ICF to ECF towards its own equilibrium potential, which is negative. That's why resting membrane potential is negative. And a little change in ECF or ICF potassium concentration can alter the excitability of the cell, excitability of the excitable cell by altering the change in the kinetics of sodium channel. Okay, change the kinetics of sodium channel, and that will alter the excitability or alter the threshold potential and upstroke of the action potential and actual action potential. Okay, so remember that the resting membrane potential is established or created and maintained by because of the potassium concentration across the cell membrane. You have high potassium inside the cell, the potassium keeps leaving and towards its own equilibrium potential, which is negative for potassium, and that's why resting membrane potential is negative. And that is established, created, and maintained in a normal healthy person negative, because potassium keeps leaving down its electrochemical gradient from ICF to ECF. All right, good. Now, what would happen in this case? there is a myocardial infarction, and from the dead cells, potassium keeps leaving from ICF to ECF. What would happen? It would result in hyperkalemia. Now, how hyperkalemia will alter the excitability of the excitable cell? What is the effect of hyperkalemia on resting membrane potential? That is the first question here, basically. Yes.
Because of the excess potassium on the outside of the cell, the leak channels, the driving force of the potassium to leave the cell will be reduced, keeping a positive charge within the cell, reducing the negativity, the not normal negative resting membrane potential to a higher resting membrane potential increase, and thus reducing the stimulus necessary to cause an actual potential.
I love that. Super. Very good. So in the ischemic zone of myocardium, or you can say infarcted myocardium or necrosed myocardium, all of you know about infarction, right? Infarction means complete stoppage of blood supply to myocardium because of the blockage of a branch of coronary artery or main stem of the coronary artery. Okay, sudden stoppage of blood supply to myocardium because there could be a obstructions or blockage in the coronary artery that will result in no blood supply to myocardium, and that will result in necrosis or death of the myocardial cells. When the myocardial cell dies because of infarction, they will release potassium. A massive amount of potassium will be released from the dead myocardial cells in the ischemic zone, and they will all go to ECF, and that will result in high level of potassium concentration in ECF, which is known as hyperkalemia. So let's break it down step by step. Now, as and Diego said very correctly, what is the consequences of hyperkalemia step by step? What is the effect of hyperkalemia? What hyperkalemia will do to the excitability of the excitable cell, or how that will change the resting membrane potential? What is the mechanism? You have a high level of potassium in the ECF now, so how that will, what would happen because of that? What would happen because of that? Writing in the chat, it will be very hard for me to see that. And I'm going to come to sodium potassium ATPase pump as well. I'll talk about that. How hyperkalemia will change the resting membrane potential. So there is a high level of potassium outside, right, in hyperkalemia, which will decrease the driving force for potassium to leave the cell. Because when you have a high level of potassium, because of, in this case, myocardial infarction, there is a reduced electrochemical gradient for potassium, and that will decrease the driving force for potassium to leave the cell from ICF to ECF. So over the period of time, potassium will keep accumulating inside the cell because there's a reduced gradient for potassium to leave the cell because there is already high potassium outside. So potassium will start accumulating inside the cell, and potassium is a cation. So that will make the inside less negative because potassium is cation, right? That will make the inside less negative or somewhat positive, you can say. Now, what is the effect of that accumulation of potassium inside the cell?
I can answer.
On the channel activity, on the channel kinetics.
I can answer this. So as we said at first, this makes the cell more excitable because it is closer to threshold. But if hyperkalemia is severe, so then the sodium channels start to inactivate because the membrane is too depolarized for too long, and then it leads to reduce excitability, or we can say paralysis, I guess. So
beautiful. Okay, hold on. Good. All right, let's go step by step. You are correct. So because potassium, good job, Sadaf. Because potassium stops or leaving from ICF to ECF, because there is a reduced gradient, the potassium is a cation that will make the inside less negative or positive. So it will partly, remember that, it will partly depolarize the cell membrane. It will drive the resting membrane potential towards is threshold potential. Okay, but it will never ever reach to threshold potential. It will never ever reach to threshold potential. That's why I use the term it will partly depolarize the myocardial cell membrane. Okay, now when the cell membrane gets partly depolarized, what would happen because of that? And setup said that, but I just want to reiterate one more time. Because the cell membrane gets partly depolarized because of accumulation of the potassium inside the cell in hyperkalemia, what would happen to the sodium channel?
Do I say it again? So the sodium channels start to inactivate.
Exactly. So it will start inactivating the sodium channel. Okay, it will start inactivating the sodium channel. So, and what would happen because of that?
It leads to like reduced excitability or paralysis.
Yeah. So let's go. That's a clinical manifestations. So that what happened is that because the sodium channels are inactivated or inactivation gate of sodium channels are permanently closed, and that will result in no upstroke of action potential. The upstroke because you cannot reach to threshold potential, you cannot fire upstroke of action potential, and you cannot fire actual action potential. Okay, all right. So to answer question number 1 here now, what would happen? What is the answer of question 1? We already talked about that. What would happen in case of hyperkalemia? It will depolarize the resting membrane potential in myocyte, right? It will partly depolarize the resting membrane potential in cardiac myocyte. That's the answer of the first question. Now let's get to the second question. Now, and we talk about that to some extent about that too. So because it is partly depolarized, it will inactivate the sodium channel, or it will close the inactivation gate of sodium channel somewhat permanently. What would happen because of that? There is decreased inward sodium current, right? Because most of the sodium channels are inactivated or closed. Very few sodium channels are available that will bring less or decreased inward sodium current that will result in small size cardiac action potential. Okay, the duration of action potential will be decreased. The size of the action potential will be decreased, right? So what would happen to the upstroke of action potential because of that? Will that be less steep or Andrew?
Oh yes, wouldn't it be? Oh yes, thank you. Wouldn't it be less steep actually because we can't get as much sodium in, so it's just going to kind of be very, very weak.
I love that. Superb. Thank you. So the phase 0, we'll talk about that in the next slide, of the cardiac myocyte action potential will be less steep. We talked about that yesterday, so I'm sure you can recollect it. So it will be less steep, and it wouldn't be reached. It will be also reduced in amplitude, height, right? So it will reduce. It will be less steep. It will be also reduced in amplitude because now there are very less sodium channels are available, which will bring the very small amount of inward sodium current, right? Because most of the sodium channels are inactivated in hyperkalemia, and less sodium, there is decreased inward sodium current, which will decrease the slope, or this will decrease the steepness of the phase 0 cardiac myocyte action potential. It will also decrease the amplitude of the cardiac myocyte action potential, right? Good. And because of that, what would happen to the phase 2 now? What would happen to the phase 2? Phase 0 is reduced in size. Reduce is less steep, reduce in amplitude because there is less inward sodium current. How that will impact the phase 2 and phase 3 of cardiac myocyte action potential? Yes, Daiju.
It will be less, more pronounced. The slope will be lesser. It will be longer, and thus restoring membrane potential will take much longer than usual.
No, my answer, answer me simple. It's a simple. I just want to break it down very small pieces. What would happen to phase 2? Phase 2 will be shorter, longer, same play 2, or decrease or less play 2. It will be is that regretting or repolarizing earlier? It will be shorter play 2 or no?
We'll get shorter and lower amplitude.
The amplitude is lower, I told you, but what would happen to the play 2?
Shorter.
Shorter. Why?
Because so less calcium entry we get.
Why?
Because the membrane potential is less negative, so fewer calcium channels are in that state that they can open.
I love you. Superb, outstanding. So because it is a depolarized, because inside, as we discussed in the first question, the cell membrane gets depolarized. Because it is depolarized before the time, that what would happen is that will reflexly inactivate the L type of calcium channel. So less calcium channels are available or recruited, which will bring the less inward calcium current, because the cell membrane gets partly depolarized, and that will bring less inward calcium current, which will decrease the play2 of phase 2. Okay, what would happen to the IKS or what potassium channel in phase 2? What would happen to potassium channel in phase 2? We talked about that yesterday. So this is phase 2 here. You can see phase 2. What would happen to the phase 2 here? Because decreased inward calcium current, what would happen to the outward potassium current?
Potassium conductance is higher.
Very good. So there is increased potassium conductance because you are far from the potassium equilibrium potential. You have depolarized the cell membrane, and that's why the potassium will try to drive out from the cell in order to bring down membrane potential towards its own equilibrium potential, right? So that will increase the voltage dependent potassium channel activity in phase 2, which is IKS channel specifically, and the activity of IKS channel is increased. It will recruit more IKS channel. It will express more IKS channel in order to increase the output potassium current in phase 2. And that's why you will lose the play2. That will be a very small play2, and you will start repolarizing the cell membrane very early. It's called early repolarization. It's called early repolarization because phase 2 will be smaller, shorter, and at the same time, you are also recruiting more potassium channel in phase 3 as well, which is called IKR channel. So that will also repolarize the phase through phase 3 more quickly. So phase 2 and phase 2 will be shorter, phase 2 will be shorter, phase 3 will repolarize sooner and more quicker, more rapidly. Okay, all right. So that's called early repolarization. It's called early repolarization. Okay, so what would happen because the because of the size of action potential is reduced, the duration of action potential, the size of action potential is reduced. What would happen to the propagation of the cardiac action potential? How that will impact the conduction of action potential now? Will that kind of action potential can be conducted to another site or not? Will that decrease conduction velocity or not?
So we should get like shorter overall action potential and shorter refractory period.
But yeah, shorter refractory period, yes, but basically the conduction velocity or the propagation of the conduction action potential conduction will be reduced, right? Decrease, because you decrease the size of action potential, you decrease the duration of action potential, right? So it will since you are not reaching to the you are not completing the cycle normally, it will reduce the conduction velocity or propagation of cardiac impulse from one side to another side, right? You reduce it. It won't be propagated easily from one side to another side. So you reduce the conduction velocity of the cardiac action potential. Now let's talk about these changes step by step in order for you to understand the same thing what we just discussed about that. Now look at that. What would happen in case of hyperkalemia? There is a cardiac myocyte action potential. Look at that. This is the answer of the first question. What would happen here? See that. What is going on here? Minus 90 millivolt is the normal resting membrane potential, right? Okay, it will get depolarized partly here because of the hyperkalemia. Hyperkalemia will depolarize it because of the accumulation of potassium inside the cell, and that will make the inside less negative or positive, depolarize the cell membrane. Now, because of that, what would happen? Now we can look at the phase 0 here. Normally, phase 0 is vertical line, steep rise, depolarization. What would happen to the phase 0 here? Look at this. We just talk about that, right? What would happen? Yes, Andrew.
Oh, yes, thank you, doctor. It's going to have a weaker increase. Okay.
Yeah, less steep, right? It is a less steep, right? And then what would happen to the phase 2? We talk about that.
It will be shorter.
Right, very good. And what happened to phase 3? Early, it will repolarize early, right? Early repolarization, right? It will repolarize very early. Now, what would happen? Look at this. This is ventricular depolarization phase 0, right? It is less steep. Now this is the EKG. It corresponds. Which part of the EKG correspond to ventricular depolarization here?
DR.
Which part of the ventricle EKG represents ventricular depolarization?
QRS.
QR.
QRS. So what would happen to the QRS? Duration of the QRS will be increased or decreased or same? What would happen to the QRS complex? See, I will put that up over there too. What would happen to the QRS complex? Will there be increased duration of action potential of QRS or not? Will that be wider or shorter, narrower?
Would it be wider?
Why?
Because there's a reduced rate of depolarization.
Who said that?
Oh, me, sorry.
Outstanding. Because there is a reduced rate of depolarization. Basically, the phase 0 is less steep now, right? Because you reduce the dB over dt, there's a decreased rate of depolarization of the ventricle, right, or cardiac myocyte, right? So that the slope is less steep now, right? It's less steep now. It is slowly depolarized it now because less inward, so less sodium. There is decreased inward sodium current. Inactivation of sodium channel is there because of hyperkalemia, which will decrease the rate of depolarization of the ventricle, and that's why it is becomes more slower, and that's why QRS complex is larger, broader. It takes more time for the ventricle to depolarize completely, right? And that's why the QRS complex, which represents ventricular depolarization in EKG, it will get wider. It takes more time to complete QRS in terms of electrical activity, right? So QRS will be more wider. Good. What would happen to the T wave here? Why the T wave is tented, and there is an early repolarization. So ST segment or QT segment becomes smaller. So because you start very early repolarization, so what would happen to the T wave?
The T wave should
beginning of-
become narrow and tall
Very good. Very good. Why it is narrow and tall?
because we have faster repolarization.
I love that. And why it is tall? You're right. You're correct. Why it is tall?
It is because of the resting membrane potential is now also less negative.
Yeah, but why? You're right. But why it is tall, T wave? Because it happens more quickly. It will repolarize very quickly, right? The ventricles get repolarized earlier and quickly at a steeper rate, right? That will make the T taller, peak T wave or tented T wave, right? Because repolarization become earlier, sooner, and it occurs at a faster and steeper rate, you can say. And that makes the tall T wave very tall. Peak T wave or tented T wave. Okay. So this is the P wave, okay? P wave represents atrial depolarization, and QRS wave represents ventricular depolarization. Remember that. You know that, right? And T wave is a ventricular repolarization. Okay, remember that. PQRST. So T wave is ventricular repolarization, ventricular depolarization, and atrial depolarization. Remember that, okay? What would happen to the PR interval? P wave is here and R is here, right? So what would happen to the PR interval in hyperkalemia?
Would it shorten because the resting membrane potential is less negative and it hyper excitable?
But it is true, it is hyperexcitable. But what would happen eventually? We just talk about that. It is hyperexcitable or it will not excitable eventually.
Low excitability, sir.
Exactly. So what would happen to PR interval?
It prolongs.
Prolongs. Very good. It takes more time for the impulse to be conducted from atria to ventricle. It will prolong the PR interval, right? Because everything gets slower. Excitability is very slow now, right? So that's why PR interval will be broader, bigger, prolonging PR interval. What would happen to the QT interval? What would happen to the QT interval? You know, Q starts from here, right?
Becomes shorter.
Shorter or longer? We just talked about that. What would happen to ventricular depolarization? What would happen to QRS? Broader, right? QRS takes more time to finish, right? So that's why it will also increase the QT interval, right? It will also prolong the QT interval. Because QRS is bigger. Yes, Drew.
Wait, so then does the widening of the QRS, is that greater than the shortening of the ST segment?
Yes.
All right, thank you.
Yeah, good. ST segment is actually depressed, also slightly depressed in hyperkalemia. So, and it will not be that much shorter. It will be slightly shorter because ST segment represents phase 2. So it will be shorter, but not that much shorter. It will be shorter, but still QRS complex is so widened, it will overall increase the QT interval or prolong the QT interval. Okay, Drew? All right, thank you. Now in hypokalemia, suppose let's assume the hypokalemia. What would happen in hypokalemia? What would happen in hypokalemia? To the membrane excitability.
Sir,
Yes.
so in hypokalemia, the membrane potential it becomes less excitable and it's harder to stimulate.
Why?
Because sorry, because it's in a prolonged refractory period, so there's no no stimulus could be applied in that time because the membrane is more positive in that.
So what happened to the level of potassium in hypokalemia?
it decreases in the ICF, so more potassium will leave the cell, causing it to be like further from the threshold.
I
more
love that.
needed.
So that the potassium keeps leaving down its electrochemical gradient, because there is a large electrochemical gradient for potassium to leave the cell. So what would happen inside become more negative. You are hyperpolarizing the cell membrane because you are driving your resting membrane potential more towards potassium equilibrium potential, since there is a large driving force for potassium to leave the cell from ICF to ECF in hypokalemia, making it more negative and making it very hard to far extend potential, because you have to have a stronger inward current, which should be in outward potassium current in order to reach to threshold in order to far extend potential. So that is that it is possible. It is possible to far extend potential, but it is very hard to far extend potential. It is very hard to far extend potential in hypokalemia. But you can, if the inward sodium current will be in over outward potassium current. But in hyperkalemia, it almost next to impossible to far extend potential, because you will inactivate the sodium channel. Okay, very few sodium channels are activated or remain, which will bring very small amount of inward sodium current. Okay, remember that. That's a major difference between hyper and hyperkalemia. But the outcome is same. They both patient presentation of hyperkalemia and hypokalemia will be the same. Will be the same. Clinical manifestations will be the same. Okay. Now let's go back to the main other questions. So we'll talk about this later on. Re-entry arrhythmias. Who can read this stem now? This part of the stem. Someone. Yes, Andrew.
Oh, thank you. Yes, I'll read it. This patient had cardiac rhythm disturbances within minutes after he felt the chest pain. He was given an antiarrhythmic drug that inactivated many of the fast sodium channels in the heart. What effect would the antiarrhythmic drug have on the resting membrane potential of the myocardial cells? What effect would this drug have on the upstroke of the action potential and on the propagation velocity of myocardial cells? And what effect does this drug have on the action potentials of the automatic cells in the sinoatrial node and on the action potential of the conduction fibers in the central region of the atrioventricular node?
Okay, so let's start with the first question. Who can answer the first question now, based on what we discussed? Yes, Amir.
Would the membrane potential become more positive? If there's less sodium, if there's less sodium leaving the cell than going in, would that make the membrane potential more positive?
So what are you answering the first question here? What is the effect of
Right,
antiarrhythmic drugs on the?
No, I wasn't trying to read the answer. I was just trying to get an idea, because it's antiarrhythmic. It's inactivating sodium channels, so sodium cannot enter. So what's gonna happen at rest? Sodium would it would make the membrane potential more positive because it's less going in, less sodium molecules going in. That's what I believe.
I think we discussed it like almost 30 minutes, the same idea, but looks like you guys are still struggling in this. What resting membrane potential is because of what?
Potassium.
Exactly. So if you give a drug that will block sodium channel, fast sodium channel, will that have any effect on RMP? Yes or no? Simple question.
No.
Yes, exactly. So there will not be any effect of the antiarrhythmic drug sodium channel blocker, because sodium has nothing to do for resting membrane potential. The role of sodium is almost negligible. Okay, the role of sodium is almost negligible. It's all about potassium that keeps leaving the cell from ICF to ECF down its electrochemical gradient towards its own equilibrium potential, because there is high potassium inside the cell compared to outside, and that will establish, create, and maintain resting membrane potential, which is negative. At rest, the conductance of sodium is almost zero. Very, very small amount of sodium is conducted inside at rest. Sodium has not, you can say there is no sodium coming in at rest. Only potassium is leaving outside from inside. So if you give a drug that will already block sodium channel, mainly fast sodium channel, that we use in clinical practice very commonly in case of post myocardial infarction induced cardiac arrhythmias, mainly ventricular tachycardia or ventricular fibrillation, we use that drug to treat cardiac arrhythmias that will inactivate or block fast sodium channel. Okay, but that will not change resting membrane potential at all. Okay. Amir, it is clear to you? Everybody?
Yeah, more clear. I was just thinking about the sodium, potassium.
So hold on. Don't think anything else. Okay, I'm
Okay.
telling you what this is right. All right, it will spread confusion to other students. Okay, and you can confuse yourself too. So just focus on what I'm saying or what we are discussing here, everybody, because I don't want anyone to miss this in the exam or when you get to second year or when you advance in medical curriculum. Anyone. Okay, period. So now what drug that you have learned in first 2 weeks that they use to block or inactivate sodium channel, that is widely used in clinical practice, that we also use to use that drug to treat cardiac arrhythmias or ventricular fibrillation or ventricular tachycardia, which is one of the most common clinical manifestations after MI and most common cause of death after MI. Most common cause of death after MI is, and one of the most common complication after MI, which is immediate complication after MI, myocardial infarction or heart attack, is ventricular tachycardia or ventricular fibrillation. And the drug of choice is what drug we use that you learned in first 2 weeks.
It'll be a beta blocker, so maybe metoprolol, propranolol, or.
Sorry, no.
Glycosides.
I mean, we use beta blocker, but not for ventricular fibrillation or tachycardia. Say that again.
Cardiac glycosides.
I'm sorry, your voice is cutting off. Say that again.
Oh, sorry. Cardiac glycosides.
You said cardiac glycoside?
Yes.
Well, we do not use, we used to use cardiac glycoside in the past, but not for ventricular fibrillation. It's very dangerous to use in ventricular fibrillation. It is contraindicated. We do not use cardiac glycosides to treat ventricular fibrillation. It can be dangerous, actually. Why? We will talk about that. Hold that thought. I have that slide because it's a part of this discussion. We'll talk about when we talk about cardiac contraction, because I want to use both full until 3 o'clock. I want to use this full list to explain all these important details today to all of you. Which drug you learned in first 2 weeks that is used by dentist as a local anesthetic agent?
Lidocaine.
Sorry.
Lidocaine. Super. Very good, Emma. Lidocaine or lignocaine that will inactivate or block sodium channel, and it is used as a local anesthetic for any kind of small surgery or procedure or dental procedure, for example, because it is a local anesthetic. It will block or inactivate the voltage dependent sodium channel. That's why dentists use it, locally anesthetize that, and you can do any kind of surgery locally or perform surgery because a patient will lose the sensation. There, you will not feel any sensations because without sodium channels, you cannot fire action potential. If you cannot fire action potential, you cannot carry any sensory information to the brain. So that's why patient will not feel pain despite there is a pain. Okay, despite there is a pain in surgery, patient cannot feel it because the sodium channels are blocked or inactivated by a drug which is very popular, very widely used in practice as a local anesthetic. Is called lidocaine or lignocaine, and the same drug is used to treat myocardial cardiac arrhythmias or cardiac ventricular fibrillation or VTEC or VFib is also lidocaine or lignocaine. Okay, there are other drugs used, but I don't want to get into that. That will be beyond the scope of your class. But I just want to talk about lidocaine, lignocaine because you learned it in first 2 weeks. Okay, it is also connected to this question now. Okay, if you use that drug, it will not change resting membrane potential, period. Because RMP is just because of the potassium leaving the cell from ICF to ECF down its electrochemical gradient, period. Okay. Now, so one of you put in the chat about the sodium potassium ATPase pump. The role of sodium potassium ATPase pump in establishing RMP is very minor, very negligible. Okay, directly. It's an electrogenic pump. I understand that, which will maintain the high potassium inside the cell and high sodium outside the cell, because you have to push the sodium against its electrochemical gradient from ICF to ECF, and you have to push the potassium from ECF to ICF against its electrochemical gradient. That's why you have to use this primary active transport mechanism called sodium potassium ATPase pump, which is electrogenic in nature. Why it is electrogenic in nature? Why sodium potassium ATPase pump is electrogenic in nature? Yes, Andrew.
Oh, because doesn't it generate a charge differential across the membrane?
Yes. So it will push 3 sodium, remember that, out and push 2 potassium inside the cell. Right, Andrew? Right? So there is always a plus 1 difference, right? There's a difference of 1. So that's why it is electrogenic in nature. The stoichiometry of sodium potassium ATPase pump is 3 sodium to 2 potassium. That makes this pump by nature electrogenic. Okay. And the job of this pump, the function of this pump is to ensure the sodium concentration remains high in the ECF and the potassium concentration remains high in the ICF. That is the job of sodium potassium ATPase pump. It will maintain the level of high sodium in ECF physiologically. It will maintain the level of high potassium inside the cell physiologically. That is the job of sodium potassium ATPase pump. Okay, all right. So it is not directly involved in creating or establishing or maintaining resting membrane potential. Okay, the job of sodium potassium ATPase pump is to keep high level of sodium in the ECF and is to keep the high level of potassium inside the cell. Period. Okay, but because of the level of high potassium inside the cell, potassium will keep leaving, and because potassium keeps leaving towards its own equilibrium potential, that will make the RMP negative. Okay, so RMP is just because of exit of potassium. Okay, that's what RMP is, because of potassium keeps leaving. So that's why question number 4 here, there is no effect of antiarrhythmic drug fast sodium channel here, because it will only block sodium channel. It will not manipulate or modify any activity of potassium channel at RMP. Good. What is 5? We will talk about that. Anyone can tell me. But what is the effect of sodium channel blocker on question number 5?
So the fast sodium channels are responsible for the upstroke. So if we're blocking the fast sodium channels, you're not going to have, I mean, I don't know if you'll have any upstroke if you're blocking them fully.
Outstanding. So it will be less steeper, right? Less steeper than what you have because of MI, as we discussed earlier. So it will be less steep, right? And the conduction velocity, or propagation velocity, whatever you say, to conduct action potential from one side to another side will be reduced, right? Will be reduced, right? So that's answer of the question number 5. If you use the drug, that's a sodium channel blocker. Very good. What is the answer of number 6? Yes, Diego.
Because this drug is blocking the fast-acting channels, it shouldn't have an effect, since it will have an effect on this SA, but not on the AV node, because that one actually uses slow leak sodium channels, and then it's the calcium channels that take over for the upstroke. So it shouldn't have.
So what would happen to the? What would happen to the phase 4 and phase 0?
So the drug would cause bradycardia, which means a slower heart rate, and less is the phase 0 upstroke, because the SA and AV node cells do not rely on sodium influx for their depolarization.
Are you sure?
Yeah, because they should be dependent on calcium.
Are you sure about that? Phase 0, phase 4, I'm sorry. Phase 4?
Oh, I said this for phase 0, not for phase 4.
So for phase 0 is not involved in the heart rate, right? is phase 4, right?
Yeah.
Phase 4 sets the frequency of the heart rate, right? The upstroke or the rate of rise up slope of phase 4 in SA node and AV node, same thing, SA node, this one. Phase 4 will set the frequency of heart rate, right, Sadaf?
Yes.
Not phase 0. So what would happen? Why there is a bradycardia? You are correct, but why there is a bradycardia? It's a very good review of actually cardiac external potential when we discuss this kind of case. So if you give a sodium channel blocker, what would happen to phase 4?
Is it gonna decrease because there's less of like the funny current? So that's why it's
Exactly.
bradycardic?
Very good. So what would happen to the phase 4? Prolong or shorter?
It's gonna be prolonged.
Very good. Superb. So phase 4 will be longer, result in bradycardia because it takes more time for a sinoatrial cell to get depolarized to threshold. Right? True. It takes more time for the sinoatrial nodal cells to get depolarized to threshold from RMP because it is longer now because you block the sodium channel, and that's why phase 4 become very long. It takes more time for the phase 4 to depolarize to reach to threshold, and that will increase the duration of the external potential overall, which will decrease the heart rate. Everybody clear? You make the phase 4 longer, right? By blocking the sodium channel. What would happen to the phase 0?
Wouldn't that be normal because it depends on calcium?
Very good. But hold on, Erin, you are right. But that's exactly we discussed. I gave a summary earlier, and I think Saraf explained that really well earlier. But I really want you guys to understand this concept really, really well. What if you block sodium channel? I agree with you. You are just blocking sodium channel. I agree, which is phase 4 of SA node. Then how that will change the phase 0? Will that change phase 0? Yes or no? That's my first question. Will that change phase 0? As you know, we discuss about cardiac myocyte because it changes all phases of cardiac myocyte, right? So why will that change phase 0 of SA node external potential? Yes or no?
Yes.
With this phase 0 will be changed or not?
It will be decreased. The slope of phase 0 will be decreased.
Exactly. The slope is less steeper, right? You can say less steeper, right?
Yeah.
And smaller. Why?
You get a flatter upstroke because depolarization is slower.
Very good. Why?
Because the SA and AV nodes slow down.
Say that again.
Because SA and AV node is slowed down.
Yeah, but what is the mechanism? Electrical ionic channel basis of that. Yeah, it does. It is phase 4 is also because of slow channel. Mainly, I know that, but it will this sodium channel blocker will also block that channel. Okay, it will also block that channel. That's why it will prolong the phase 4. Those who put in the chat, asking the questions. But why it will make the phase 0 less steep here? Antiarrhythmic drugs will also block slow sodium channel. Okay, not only fast. I know I put fast here, but it also inhibit or it has also effect on slow sodium channel activity as well. So that's why it will result in bradycardia. Why the phase 0 is less steep?
Is it because you would be starting at an even lower point?
Okay, so but what would happen to the calcium channel?
Because calcium channels will slow down.
Exactly. Good. What is okay? Calcium channels, less calcium channel. So they are. What would happen to calcium channel? It will be
slowing calcium channels influx.
Exactly. Why?
because they're voltage gated and responsive to the rate of depolarization. So
exactly. So since you prolong the depolarization of phase 4, less calcium channels will be activated available in phase 0, and that's why it's a less steep of phase 0 in SI node. Okay, that will decrease the conduction velocity overall, obviously, because you slow down setup said that slow down the conduction impulse generation and conduction in SI node that is going to the AV node and bundle of His and Purkinje eventually. So you slow down conduction velocity overall, and you will prolong the PR interval. Why PR interval will be prolonged? Why PR interval will be prolonged?
Because of the slower conduction.
Yeah. So what is PR interval?
It's the time from initial depolarization of the atria to the initial depolarization of the ventricles.
Beautiful. Great. So why it is prolonged now? And you said that earlier. Why it will prolong?
Oh, sorry, because increased time in depolarization.
Very good. Of phase?
Phase 4.
Very good. Super. Very good. Beautiful. All right. Let's go to the next one. Who will read this? Andrew. This is a real life example, real life case that I faced it. I'm telling you, this is a real life example. I wrote this case on my own. This is the best way to learn cardiac electrophysiology or cardiac arrhythmias, hyper and hypokalemia. Okay. Next question. Andrew, can you read this, please?
Oh, sure thing. Thank you. I'll
Yes.
read just this part. So soon after the patient arrived at the hospital, the activity in the vagus nerve fibers to the heart increased reflexively. What electrophysiological effects would increased vagal activity have in the autonomic cells in the SA node? And what electrophysiological effects would increased vagal activity have on the conduction fibers in the AV node?
Okay. So who can answer this question? The first question. What is the effect of increased parasympathetic activity, which is the vagus nerve mainly? You know what is the vagus nerve? Cranial nerve, right? It's a 10th cranial nerve, 10th parasympathetic nerve. Why it's called vagus? Anybody knows why it's called vagus? Why it's called vagus? Because the course of this nerve is vague. Okay, if you open any part of the body except upper and lower limb, you'll find out this nerve, branch of this nerve. It's a vague course, VAGUE, vague course, vagus nerve. Okay, how that will change the activity of SA node? What is the electrophysiological effect of vagus nerve on SA node activity, or action potential, morphology or duration, or overall SA node configuration? Yes, Mrs. Abraham.
Hello, Dr. Scholl. For parasympathetic from vagus nerve, it should decrease the in sodium and calcium currents. And then that'll hyperpolarize and then decrease the slope of the potential and decrease the firing rate.
Okay, you said that, but there are some corrections required, which I will correct it. Anybody else would like to elaborate that?
So it's the acetylcholine will bind to the muscarinic receptors on the SA node. It's the M2 receptors, which are GI receptors. So it'll inhibit adenylyl cyclase. So decreasing cyclic AMP, thus decreasing the current, which causes the decreased rate of the phase 4 depolarization and then decreases the heart rate.
Very good. Good. So, good. So there are three channel activities are involved, right? Three channels activity. So ACH will decrease the inward sodium current, right? It will decrease the activity of funny sodium channel. It will decrease the inward sodium current. So that will prolong the phase 4, right? Right? Because that means it will take more time to depolarize the cell membrane and to reach to threshold, because you make the phase 4 longer because you decrease inward sodium current through funny channel, right? By ACH, number one. Now, So what is the other inward current that will be decreased? We talked about that yesterday. Calcium, right? T type of calcium channel, right? T type of. So that will be also decreased because of ACH will decrease the activity of or decrease the expression and recruitment and population of the calcium T type of calcium channel in the axonodal cell. That will also decrease the inward calcium current, right? Right. So together there is a decreased sodium current through funny channel. There is decreased calcium inward calcium current through T type of calcium channel. Okay. Okay. That's number one. What would happen to level up? What would happen to potassium channel, which is the major driver or major factor here in making the phase 4 longer?
Wouldn't it increase?
What do you say there again?
Wouldn't it increase? Go up?
Very good. So it will activate the potassium channel, IKACH channel, potassium channel, and it will recruit more potassium channel, activate more potassium channel. That will increase the outward potassium current through the IKACH channel, and that will hyperpolarize. Okay, that will hyperpolarize the cell membrane, and that make this phase 4 longer, more longer. Because that means you have to wait for a longer period of time to reach to threshold potential in order to fire action potential, right? So combination of three things: number 1 and 2, sodium, there is decreased inward sodium current through funny sodium channel. Second, there is decreased inward calcium current through T type of calcium channel. Number 3, there is an increased outward potassium current through IKACH potassium channel by ACH, and that all three together will prolong the phase 4, and that's why it will be very hard to depolarize the cell membrane quickly in phase 4 in SA node. It takes more time to reach to threshold, and that's why it will result in bradycardia or decreased heart rate. Right? M2 receptor, as Jama said, M2 receptor in SA node, ACH will interact or bind to the M2 receptor, will activate M2 receptor. There is a sequence of events that will occur downstream pathway through the cyclic AMP mechanism, and that will eventually, the final target is this channel. It will modulate this channel activity. It will decrease inward sodium current. It will decrease calcium inward current, increase outward potassium current. That's all three channel activities will be modulated or phosphorylated. Basically, you can say that, and the outcome is prolonged phase 4, decreased heart rate or bradycardia by vagus. Okay. Can anybody tell me? This is require critical thinking. Why the vagus nerve activities increase in MI? Why patient has an increased vagus activity reflexly? And I use the word reflexly here too. Why it is increased?
Would it be because the phrenic nerve is in the pericardium? So if there's something, pathological happening with the heart, then the sympathetic innervation would be compromised?
I agree partly with you because there is a direct mechanical effect of irritation of the phrenic nerve, which is pericardial area and diaphragm all together. That will basically stimulate vagus nerve to some extent. I will agree on that. But what is the major factor that will actually increase the vagus nerve activity? It's a protective mechanism, actually. Yes, Drew.
Does that have to do with oxygen consumption?
So what would happen?
Of the cardiac tissue?
So that will do what?
It would make it so that there's decreased oxygen consumption of the myocardial tissue.
You are correct. But what would happen when there is a myocardial infarction? What would happen to sympathetic nervous system? Because we are trying, patients likely to produce cardiac arrhythmias, for example, right? Increased heart rate, increased tachyarrhythmias, or it happens because in MI, it will result in increased sympathetic activity right? In response to MI. And there is increased exaggerated sympathetic tone or activity, and that can be fatal to the person. That can kill the person. So after certain period of time, to balance out excessive sympathetic activity, you will activate the vagus nerve reflexly to maintain sympathetic and parasympathetic balance, homeostasis. Dhruv, okay? Because in MI, you decrease the myocardial cells are died, and that will decrease the cardiac output. There is a cardiogenic shock or decrease. It has pump failure, there is a decreased cardiac output, decreased perfusion to the tissues. That will activate the sympathetic nervous system to increase the cardiac output. And that is dangerous in that patient, because that patient requires more oxygen. You have increased sympathetic drive, which will increase their heart rate further. So that will increase oxygen. That will increase the requirement of oxygen consumption, and the patient is likely to develop cardiac arrhythmias as well because of hyperkalemia. Okay, so after a certain period of time, the vagus nerve will be activated in order to suppress the activity of sympathetic nervous system, or to balance out the effect of sympathetic nervous system, overdrive of sympathetic nervous system. So that's why there is a reflex vagus nerve activity that you will see in these patients. Yes, Amir.
Oh, thank you, Dr. Shah. So basically, just to clarify what you're saying, it's because in the MI, your heart is beating, like, is working hard to pump oxygenated
Yes.
blood to the rest of the body. So
Yeah.
as a defense mechanism, your body's going to want to slow down your heart rate to parasympathetic activation, so
To
that
decrease the requirement of oxygen, right?
increased requirement to slow down the heart rate so it
Yes.
doesn't tire itself out. Okay.
Excellent.
That makes
Excellent. Good. All right. So that's the reason why I put this question here, because you will see, I see that many patients has this problem, that vagus nerve activity is increased reflexly. Good. Now, who will answer question number 8? Which is very easy to answer now. It will be the same, right? Same mechanism, but on the top of that, what is the effect of ACH on the phase 0, L type of calcium channel?
We get flat in phase 0.
What would happen to phase 0?
It gets flat. It gets short.
Shorter, less deeper, right? Less deep, right? So that will also contribute in decreasing the size of action potential, duration of action potential, and that will also be difficult to propagate. And that's why upstroke of the phase 0 will be reduced, and there is decreased conduction velocity or propagation of the impulse, right? Decreased conduction. Good. So that's the last question here for this case. Who will read this question? Anyone? Yes, Andrew.
Yes, thank you, Doctor. I'll read it. So about 1 hour after the coronary artery became occluded, conduction in the bundle of his ceased abruptly. The conduction block persisted for several days. At approximately what rates would the atria and ventricles beat after his bundles had been completely blocked? And where do the impulses originate that initiate the atrial and ventricular contractions in such a patient with complete atrioventricular block?
So who can answer that? Who can answer that? This will actually give you an idea about the rate of external potential firing, or rate at which SA node will fire external potential, and the bundle of his or Purkinje fire external potential. That will help you to answer the question in the exam actually. The complete dissociation. Who can answer this? Yes, Taigo.
Is it related to the overdrive suppression, where if by the pacemaker, it's like a ectopic pacemaker, if the SA node is not working, then the next one in line with the faster rate will take over the pacemaker activity. In this case,
right,
I think AV, which is 40 to 60, will be the new pacemaker.
It is AV node or something else? I mean, AV, there is AV block. I said that in the question. There's AV block. It's a complete heart block, right? It's a 3rd-degree AV block. So what would happen?
So it will be set by the Purkinje fibers.
Very good.
15 to 20.
Right. Well, it's 20 to 30 or 15 to 20, what book says, yeah. But book, slightly, it's not exactly correct. This is more correct, but it's fine. You go by book. So it is less than, definitely way less than the SA node, right? So they both have their own rhythm, because there's a dissociation between atrial and ventricular rhythms, because there is a complete AV block or third degree AV block. So impulses which are generated in SA node will not be conducted to bundle of His and Purkinje through AV node, because AV node is blocked. The road is blocked. It will not let the impulse to pass down from SA node to bundle of His or Purkinje. So SA node will fire impulses at its own rate, which is 60 to 90 beats per minute, and ventricle will fire its impulse because that is set by the Purkinje and bundle of His, mainly Purkinje system, which is 20 to 30 or 15 to 20 beats per minute. So it's called dissociated atrial and ventricular rhythm, because there is a complete disconnect because of AV block. Okay, AV block. But this is a compensatory response. Our body will never let us die. Despite this, there is AV block, complete heart block. The impulses are not being conducted from SA node to bundle of His, because there is AV node blockade. So SA node will fire impulses, and that will regulate the beats, atrial beats or atrial rhythm by 60 to 90 per minute, and the ventricle will beat at its own rhythm. It's called idioventricular rhythm, because it's set by the Purkinje system, which is 15 to 20 or 25 to 30 beats per minute. So they both chambers will contract or rhythm. They will have their own rhythm. Okay, they would have their own rhythm, but still it will keep the person alive. That's the beauty of the heart, or compensatory response. Okay. Now, Andres talk about beta blocker, because this is the last question. Andres talk about beta blocker. Remember, beta blocker, this is a good question, and it's very important for the exam. So I would like to talk about that, since it is important for the exam. Otherwise, I will not talk about that. And since he brought it up, in what cases, think logically, you can use beta blocker in terms of cardiac arrhythmias? Think logically, and it is connected to this part also, this particular question now. In what case you will use beta blocker? We talked about that yesterday, actually, in the class.
VFib?
What? Huh?
Ventricular fibrillation?
No. Contraindicated.
Sinus tachycardia?
Very good. So sinus tachycardia, yes. If it is tachyarrhythmias, yes. If atrial fibrillation, yes. Atrial flutter, yes. Atrial tachycardia, yes. Supraventricular tachycardia, yes. Why? Supraventricular means the impulses are produced above the level of AV node. AV node and above the level of AV node. Okay. So if the SA node is firing impulses irregularly, right, and without and in no rhythm, this rhythmia you can say, okay, and above the level of AV node, they are firing impulses irregular impulses firing, or external potential firing, okay, in multiple directions. Atrial tachycardia, supraventricular tachycardia. Why you prescribe beta blocker in that case, but not in ventricular fibrillation?
It's because one of the effects of beta stimulation is increasing in conductibility and contractility. By blocking it, you curve that, reducing the conductivity.
So beta blocker will reduce the force of contraction, heart rate, conduction velocity, yes, which will decrease the stroke or cardiac output, that will decrease blood pressure. Yeah, but what about the rhythm, rate and rhythm here? What is the goal here? Why we have to prescribe beta blocker if the impulses are produced above the level of AV node? What would happen if we do not control the impulses that is going to ventricles? Yes, and Andrew.
Oh, yes, thank you, doctor. So if basically in this case, if we didn't use a blocker, the heart rate is just going to keep going up. It's just going to keep contracting.
No, I'm talking about, I'm answering the questions that Andrews asked earlier. That's a general question. He said about beta blocker. We cannot use beta blocker in this case. Okay, I'm just saying that why beta blockers are used in atrial tachycardia or fibrillation or atrial flutter or supraventricular tachycardia. What's the goal? We talked about that yesterday.
Can I try, Dr. Shah?
Yeah, please.
Because beta blockers slow SA node depolarization, slow AV node conduction.
Very
So
good.
Yeah, the person goes to in like a relaxed form.
Very good.
Yeah.
Like it. All right. So remember that we talk about that all the impulses which are generated at the level of AB node, SA node, above the level of AB node, they all will go to eventually where they're gonna go. If the rate of atria is 180 per minute or 200 per minute, in case of atrial fibrillation or flutter or tachycardia, what would happen to rate of ventricles?
Would it increase?
Very good, Andres. Why
And
it will
it
increase?
would. Well, there's more stimulation from the SA node, but then there would be less ventricular filling because it's
Good.
just
Yeah, please,
constantly
hold
stimulating.
on. We are going there. Good. So all the impulses which are generated at higher pace in SA node or above the level of AV node, they all will pass down to ventricle. That's what Andres are saying, which is correct. They all are passing out to ventricle, and that's not good. That will result in increase in ventricular rate. Okay, increase ventricular rate and myocardial demand. So because of that, what would happen? Now we can say, Andres.
There would be reduced filling in the
Very
ventricles.
good. Right. So there is a reduced filling in ventricle. And what would happen because of that? Decreased cardiac output, right?
Yeah.
Right. It could dangerous. Very good. So we want to control the rate. Our goal is not we are not worried about atrial rate there. We are worried about ventricular rate. So we give beta blocker in all these clinical conditions, as I just mentioned, to control the rate that is going from atria to ventricle to keep the ventricular rate in normal range. Good job, Andres. To prevent to have enough time for a ventricular filling and to maintain the cardiac output. Otherwise, person can die, right? So that is the goal of giving beta blocker, right? Right. So remember, that's what we have to give beta blocker in a patients who have atrial arrhythmias, not ventricular arrhythmias. For ventricular arrhythmias, we give other drugs, mainly sodium channel blocker, in some cases beta blocker too, but depends. There is another type of arrhythmias where we give calcium channel blocker. Okay, that's we use beta blocker, calcium channel blocker. Beta blocker, I just gave you that name, supraventricular tachycardia, where we also use other calcium channel blockers to suppress supraventricular tachycardia or atrial fibrillation. And those drugs are verapamil and diltiazem. Verapamil and diltiazem, they are L type of calcium channel blocker because they are expressed in conduction system and vascular smooth muscle both places. Okay, you don't have to know that for the example. I'm saying that, but beta blocker question is very important for you guys to understand that why we prescribe beta blocker. Okay, now let's get here in cardiac glycoside. We give cardiac glycoside in a patient who have a congestive heart failure. Why? And you learned about this, so it's not new. Why we prescribe cardiac glycoside or digitalis in a patient who has a congestive heart failure? And the mechanism is here. If you understand this slide, you'll be able to answer one question correctly in the exam. I can tell you that. But you have to understand this slide really well. Cardiac glycosides, digitalis or digoxin, it will increase the force of contraction it's a cardiotonic drug that we prescribe. We used to prescribe, we still prescribe it, but now we don't prescribe that much because it has a very narrow therapeutic index. We talked about that in pharmacology earlier. Cardiac glycoside is not safe to use because it has a very narrow margin of safety, very narrow therapeutic index. It has a lot of serious life-threatening side effects, especially cardiac arrhythmias. So we try to avoid this drug to use nowadays in case of congestive heart failure because many advanced medications, newer drugs are available to treat congestive heart failure. But still we use it sometimes, rarely. Okay, so what is the basis of using cardiac glycosides in congestive heart failure? What is the mechanism? Yes.
So by reducing the action of the sodium potassium using the cardiac glycosides, you increase the amount of sodium that there is, and that sodium gradient is used by the sodium calcium pathway, the sodium pump,
A sodium
I guess,
channel exchanger.
the sodium
Okay.
exchanger. So
Yeah, or counter
you
transfer,
retain
same thing. Yeah.
counter transfer. You retain more calcium intracellularly, which will be used for muscle myocyte contraction. So it will be available. The stroke will be greater.
Very good. So that will increase the force of contraction. So let's go step by step. Who like to go step by step? Otherwise, I will say. Anybody wants to try step by step? You have a figure before you. It is there in the exam. Some way it is tested in the exam. You all have to know this. Step by step. You learned it in first 2 weeks. So that's why I'm expecting you some. Yes, Erin.
So because you're blocking potassium from entering, the sodium won't be able to leave. And on the pump on the right, sodium will end up coming in, so calcium won't leave. So you'll have increased intracellular calcium, creating more contractions.
Excellent. Very good. Beautiful. Thank you, Erin. So remember, there is a membrane-bound sodium potassium ATPase pump. It is electrogenic pump, right? We talk about that. That pump will be inhibited by cardiac glycoside. Okay, cardiac glycoside mainly bind to the site on which potassium binds basically. But once it binds, it will change the configuration of this sodium potassium ATPase pump and will inhibit this pump or block this pump. Okay, so cardiac glycoside digitalis will basically bound to sodium potassium ATPase pump and inhibit the activity of the sodium potassium ATPase pump. Okay, now because of that, what would happen? Since you decrease the activity of sodium potassium ATPase pump, less sodium will be pumped out, right? Less sodium will be pumped out against its electrochemical gradient. So that sodium will stay inside the cytoplasm, and that will increase the sodium concentration in the cytosol. Okay, so now there is a very high sodium concentration in cytosol that will decrease the inward sodium gradient here. Because since this is a very high sodium concentration, it will inhibit this sodium calcium exchanger mechanism, because this is already high sodium. So because this sodium is very high, it will suppress the sodium calcium exchange mechanism here, because the cell doesn't want sodium to come inside now. There's already high sodium inside. So because since there is a high sodium, this high sodium will inhibit the activity of sodium calcium exchanger, which this is also an electrogenic counter transport or exchanger mechanism. 3 sodium comes in and 1 calcium goes out. 1 calcium goes out and 3 sodium comes in. It is also electrogenic in nature. But since you have high sodium inside, this exchange mechanism will be inhibited or suppressed. Okay. So since this is suppressed, sodium cannot come inside. If sodium cannot come inside, calcium, which is already there inside, cannot go outside. Okay. Because you are suppressing this pump. Since you suppress this pump, calcium cannot go outside. So calcium will stay inside the cell. It will increase the cytosolic calcium. That will increase the force of contraction by increasing the actin myosin filament sliding, or you can say movement of the actin over myosin. An increase in actin myosin interactions will increase the force of contraction in the myocardium, which will increase the stroke volume and cardiac output. That's the original problem in congestive heart failure. The people who have a congestive heart failure, their cardiac output is decreased, and you want to increase their cardiac output, right? That's a goal, right? So how can you increase the cardiac output? Because their muscles are weak. In congestive heart failure, the muscle become weak, their cardiac output is decreased, and that's why you want to increase the strength of the muscles by increasing the force of contraction, and that occurs because of calcium. Calcium is a direct determinant of actin myosin cross bridge formation. Higher the calcium, higher the number of cross bridge formation occur between actin and myosin. Higher the cross bridge formation, higher the cycling of the actin myosin filament. Higher the cycling, higher the tension develop. Higher the tension develop, higher the contraction or higher the force of contraction. Higher the force of contraction, higher the stroke volume. Higher the stroke volume, higher the cardiac output. Higher the cardiac output by Ohm's law will increase the blood pressure to maintain the tissue perfusion. That was the original problem in congestive heart failure. So that's why we use this drug to treat patient who has a congestive heart failure, because you want to increase the calcium concentration in the myocyte to increase the cycling or to increase the tension, increase the cross bridge formation, between actin myosin. So you can generate more cycle, you can generate more tension, you can generate more force of contraction, and you can increase stroke volume and cardiac output. That's the basis of using cardiac glycosides in congestive heart failure. Remember, there's a calcium-induced calcium release. So when there is a more calcium, which is a specific mechanism to cardiac myocyte, if you increase the calcium inside the cell, it will pull out more calcium from SR into the cytosol. Okay, it's called calcium-induced calcium release. Calcium-induced calcium release. Remember that for the exam. Okay. Anybody has any follow-up questions on this? Clear, everybody? Make sure you go through this all three panels figure that I have in my PowerPoint yesterday as well that I posted. This is very important, and you guys are really good at that, I know. So I don't want to go over on that. But anybody can tell me, this is what is this? What is this heart rate? Tachycardia, bradycardia, or this is normal heart rate, okay? This is at rest. So this is called, what is this heart rate and what is this heart rate? Why the heart rate is increased here?
Middle is Brady and the bottom is Tachy.
Why? Why bottom is Tachy?
There is an increased level of AV signaling.
No, I know, but why in tachycardia the heart rate is increased when there is sympathetic stimulation? What would happen in sympathetic stimulation? That will increase the heart rate. What's the molecular mechanism?
Isn't this the beta 1 receptors?
Very good. What's the mechanism again?
Beta 1 receptors are stimulated to the GS. GF increases cyclic AMP. Cyclic AMP increases calcium. Calcium binds to those troponin, or it moves troponin and binds to the myosin head. We have the Kreisberg cycling continuously. I think so.
Okay. So what would happen? What would happen to the channel activity? You're right. What would happen to the channel activity?
You would decrease the flow through the funny channels and then increase the potassium efflux out of the I'm sorry, it's the opposite. That's
parasympathetic. Yeah, you're right. You're right. I get it. I know you know that. It's a sympathetic effect, right?
Yeah, So it would decrease the size of phase 4.
Very good.
Yeah.
By inhibiting the inward sodium, by increasing the inward sodium current, and by increasing the inward calcium current, right? Inward sodium current is increased because of funny sodium current, right? And it will increase the inward calcium current by T type of calcium channel, right? Which will shorten the phase, as you can see here, which will result in increased heart rate, right? Because you can easily depolarize the cell membrane to threshold. So that's why heart rate is increased. Same, you can apply the same concept to contractility, but contractility is more about calcium, less about sodium. So sodium does play a role, but it's mainly calcium. So for contractility, it will just increase the inward calcium current mainly. And for conduction velocity, it will increase mainly the sodium and calcium both, but mainly calcium. Okay, remember that. Because the calcium is responsible mainly for phase 0 in SA node or AV node, but mainly SA node we talk about here. Okay, all right, good. So we talk about normal bradycardia, tachycardia. This is very important table for the exam. Make sure you go through that and we talk about that. Okay, we talk about that. So you all know that. What is the effect of sympathetic stimulation on alpha-1 receptor? We talked about that yesterday. We talk about that in autonomic. It's a very good review of autonomic nervous system. What would happen to alpha-1 receptor under sympathetic stimulation? Yes, Andrew.
Oh, wouldn't it constrict?
Constrict what?
Oh, the vascular smooth muscle, like
which part? Which area?
The splanchnic.
Yes, Mrs. Abraham.
I was gonna go through the pathway, but Mr. McGuire can keep going.
Yeah, pathway is okay. Signaling pathway, make sure you go through signaling pathway. But I'm not going to taste too much for signaling pathway in this exam. So don't worry about signaling mechanism.
Yes, sir.
Alpha 1 is basically what? What is the signaling molecule or mechanism in alpha 1?
GQ, IP3.
GQ, right? Phospholipase C, right?
Yes, sir.
Right? IP3, DAG, right? But don't worry about that in the exams. That's why I'm not emphasizing that here much. Alpha 1 will constrict the skin and, and splenic region blood vessels, right? Mainly, we talk about that. And that will increase the blood pressure, right? Increase the blood pressure, right? We talked about that yesterday. What is the effect of beta 2?
Oh, I'm sorry. Yeah, is it cause relaxation?
Yeah, relaxation of what blood vessels?
Oh,
skeletal muscles, arterioles, right? Skeletal muscles. Skeletal muscle, arterioles, Andrew. Okay?
Thank you, doctor. Thank you.
All right. Okay. So we talk about this. Now, what would happen? Now, this is very important concept. Why we are worried about in this patient? Why we are worried about arrhythmias in this patient? We talk about this concept. The phase 2 is shorter. The duration of action potential is shorter. Obviously, that will decrease the duration of action potential, right? Because phase 0 is less steep. As you can see here, phase 2 is shorter, right? Phase 3 will repolarize very quickly because you activate and express and recruit more potassium channel, mainly IKR channel. So that will decrease the duration of action potential here, making the phase 2 very shorter. Why we are worried about this? We talked about that yesterday. What's the problem in decreasing phase 2? Or overall duration of action potential, if you decrease it, what's the problem in that?
Because the the refractory periods are shorter, allowing for a lesser stimulation to actually generate the next one, maybe causing an arrhythmia.
Outstanding. So since you reduce the duration of action potential, here phase 2 is reduced very small. You can see here, for overall duration of action potential is reduced, it will also decrease the refractory period. Okay, this is the refractory period of the myocardium. So this becomes more smaller. If the refractory period becomes more smaller, the myocardial cell become more excitable prematurely. Before they are supposed to excite, they'll be prematurely more excitable, and that can result in another action potential to be fired. They are more likely to fire another action potential because you have shortened the refractory period. Okay, you have shortened refractory period, right? And that's why you can easily fire another action potential in the middle of actual action potential that will result in arrhythmias. That's why this patient develop arrhythmias, because of the decrease in refractory period. Okay, decrease in refractory period. Now there are 4 different type of refractory period here. We'll talk briefly about that. ARP, ERP, RRP, and SNP. Who can, and you learn about 2 period earlier. What is ARP stands for? Absolute refractory period. Why is called absolute refractory period in terms of channel activity? What channels are playing role there in ARP? Absolute refractory period, where no matter what, how stronger is the stimulus, you cannot fire action potential. Absolutely no. Absolutely no. That's why it's known as absolute refractory period. Why? And it has to be this length, this normal length of the ARP. If it is reduced, then it can result in arrhythmias. You can fire another action potential because myocardial cells are more excitable and more often excitable. More excitable and more often excitable. Yes, Sadaf.
The sodium channels are inactivated, so no matter what happens, they will not be open.
Exactly. So all the sodium channels are mostly inactivated in ARP. So no matter how stronger is the stimulus, there is no inward sodium current, right? Because the sodium channel gates are closed or inactivated. So that's why no matter how strong is the stimulus, the gates will not be open, and there is no inward sodium current. And you have to have an inward sodium current to fire upstroke of action potential, right? To reach to threshold and to fire upstroke of action potential. So that's why that ARP, no external potential, can be fired. What is ERP? Effective refractory period.
Is it that at this point
period.
the sodium inactivation gates are closed, but the other ones are open?
So sodium channel will start recovering, covering. It's not recovered yet. They will just start recovering. Okay, in ARP, all sodium channels are closed, inactivated, period. When you get into ERP, when ERP is over, the last part, ERP is actually including ARP, but the last part of ERP, this part especially, okay, the sodium channel will start recovering, just because they all are completely inactivated in ARP period, and they will start recovering at the end of ARP. Okay, during this part, they will just start recovering. But they are very small number of sodium channels which are recovered in ERP, which will not bring inward sodium current in a quantity that can drive membrane potential to threshold to fire external potential. So it's not strong enough. That number of channels are still not expressed enough that can drive membrane potential to threshold to fire external potential. Okay, so because they just start recovering, they are just start reopening. Okay, so it is not. You cannot fire external potential. If you fire, it will be very tiny, and that cannot be conducted to the next site. That can be propagated. Okay, that's ERP. Remember, what is RRP? That you know. RRP, you know. What is RRP? Andrew.
Oh, would it be relative refractory period?
And what is that?
That's basically where we can fire another active potential if we just have a strong enough current come by.
Very good. So that what strong current? What current? Inward current or outward current?
Inward current.
Very good. Very good. So if you increase the inward current, which will be in the outward potassium current in the relative refractory period, that means you have to recruit, you have to express, you have to populate, you have to turn on more sodium channels in order to get more stronger inward current, and that in that case you can fire external potential, right, Andrew? But what would happen if cardiac myocyte fire external potential in RRP? What would happen? Which is not desired, right? It's not desired, right? We don't want that to happen. What would happen if you fire external potential in RRP? Yes, Jasmine.
It'll have a shortened plateau.
Yeah. So it will. What would happen to morphology? It will be abnormal morphology of external potential, right? The configuration of external potential will be abnormal because you are firing external potential in the middle of RRP in the regular external potential. You open up a more inward sodium current, more to outward current that will fire external potential. So that will mess up the previous normal external potential. It will result in abnormal configuration or morphology of the external potential. Okay, that will result in cardiac arrhythmias. Jasmine, very dangerous, very dangerous. Okay, now let's get to the last supranormal period. What is SNP? Look at the name supranormal period. Look at the name supranormal period. Supranormal period. Look at the name. Why is it called supranormal period?
It's a phase where it's more excitable than normal.
Very good. Why? You're right. That's very true. Because look at them, supranormal. It is highly excitable. Why? What makes it highly excitable?
Is it that because the sodium channels are fully recovered?
Very good.
Okay.
Very good. So almost all sodium channels are recovered, available to fire another external potential. So a little stimulus can fire external potential during the supranormal period. Okay, clinically important because they target this period to treat various cardiac arrhythmias. Actually, okay, supranormal period because all the sodium channels are recovered, fully available to bring inward sodium current and are ready to fire another external potential. Right? Very good. Why sodium channels are recovered completely in SNP? What makes the sodium channels available completely in SNP? What is the driving factor there? What is the driving force, or what is the triggering mechanism that will recover all sodium channels available in SNP? Anyone?
Does it have something to do with like the membrane potential not reaching negative 90 millivolts yet? So because it's like slightly higher, that's why
So
it's.
but what would happen because of that? What would happen? That's my question here. What would happen in SNP period that will make the sodium channels are recovered completely? I agree with Emma. She's correct. Why SNP is so dangerous? Like why sodium channels are available completely before even you reach to RMP? If you look at that, you start it before even reach to RMP here around minus minus 80 minus 90 millivolt approximately.
Is it related to the inactivation gauge still being open before reaching full membrane resting potential?
That is true. Very good. Very good. But what makes it highly sensitive to for another depolarization? What in terms of membrane potential that will make it likely and make it excitable, super excitable actually, more than normal excitable to fire another external potential.
Well, S&P is closer to threshold, so it's just easier to make that mark if you
Exactly. Very good. Very good. So you are very close to threshold. You are not reached to RMP yet. The estimated potential yet very you are still away from RMP, and that will make it very easy to fire external potential at that stage because and that will also actually compound, or that will also actually help or support the sodium channel record very quickly actually, because you are actually going away from the sodium equilibrium potential, right, Emma? You are going more towards RMP. You are far from sodium equilibrium potential. That will also increase the sodium channel recruitment and increase conductors of sodium at that SNP stage, right? Driving force, I mean to say, increase driving force of sodium. Sorry, I misspoke, not conductance, the driving force, because you are away from the ENA, right? Further you go, further you increase the driving force on sodium. That's another reason why it will compound with the number of sodium channel open, or it will actually help increasing more sodium channel in that way, because it's basically reinforcing effect or positive feedback mechanism, as you learned in neuronal external potential. So that will actually open up more and more sodium channel, recruit more and more sodium channel, make the cell more and more excitable. So SNP is very dangerous period, and that's why they use SNP. The people who design the drug to target that period specifically to treat various cardiac arrhythmias, SNP. Okay, all right. Any questions? It's very important concept. From hyperkalemia, we talk about that. Any concerns from here? We talk about that everything here. But any other questions that Amir?
Yeah, Dr. Shah, can you just reiterate those last few points? 'Cause I think I lost track as you were explaining it.
I'm sorry, so that for the supranormal period?
No, that last point you were making on the last slide. Could you like reiterate those last few points? Because I kind of lost track when you were explaining it.
This one, SNP?
Yes.
Yeah, so what Emma said is that like you have still not reached to RMP yet, right? Look, SNP starts here, right? Right? So you are away from RMP, right? And all sodium channels are recovered when you are in SNP period. So you can easily fire external potential. The cell is more excitable than normal.
After the RRP, because the inactivation gates are open.
Yeah. I mean, all sodium channels are basically available. All sodium channels are activated, available. Yeah.
They're available now, and the sodium channels are open, but I mean, inactivation gates are open, but the memories are available and ready to open in response to a stimulus, which is why they're more amenable.
Okay, let me make it more simple. Because you are still very close to threshold, right? If you are here, you are close to threshold, right? You are still far from RMP, right?
Yes.
So that will make it easy to make the cell more excitable. You see my point, right?
Yeah.
It's clear now?
Yeah, that makes more sense.
Because you have not
Yeah.
reached to negative point, negative RMP yet. You're still far from that, right?
But you're close. Yeah.
So you can
we're
easily
close
you can
enough.
easily reach to threshold quickly, right?
Yeah, I get that. Yeah.
Okay.
That makes sense. Thank you, Dr.
No problem. Any other questions? Hyper and hypokalemia, very important concept. The same clinical presentation. EKG is the only way you can see that. I mean, here I have EKG. What would happen to the EKG in hypokalemia? Look at this. There is a ST depression, T wave inversion, or flat T wave, or low T wave, or ST inversion in hypokalemia. Okay, but you can see the prominent U wave. Don't worry about that for the exam. But remember that there is a low T wave and low ST segment or ST segment depression. I mean, ST segment, flat ST segment, or an inverted T wave mainly in hypokalemia. Okay, why it is like that? In hyperkalemia, the T wave is peak. We talk about that, right? Why T wave is peaked or 10K T wave in hyperkalemia? Who can revise that? Who can reiterate that what we discussed earlier? Why it is a peak tall T wave basically, or peak what 10K T wave? Why is a tall T wave in hyperkalemia? In hypokalemia, it's usually flat or inverted. Why it is like that? Why is tall?
Because repolarization is more steep and it happens faster.
I love that. It's happen more faster and more. So what would happen to the duration of the T wave here? Length of the T wave. Shorter or longer?
It would be shorter.
I love it. Superb. So T wave duration will be shorter. Okay, the length of T wave will be decreased, but the height of T wave will be increased, right? Because repole is very fast and very steep at a very steep rate, fast, quicker, sooner, but it will be very quick, right? So it is a sooner, occurs very quickly and occurs at a steeper rate, right? That's why the T wave is tall, because it occurs very repolarize very quickly and very fast. So that's why the T wave is very tall. Okay, and it occurs very quickly. That's why the T wave is shorter in terms of duration. Shorter T wave because it occurs very quickly at fast pace, and it occurs very at a steeper rate and earlier, sooner, quicker. That will make the T wave tall, peak T wave. Okay, peak T wave. Good. Why the repolarization is quicker? Why phase 3 is quicker? Happening very steep. It's steeper and quicker. Why? What's the molecular mechanism? The channel activity. Why it will be quicker, steeper? And also bigger, right? Compared to here normal, it's bigger, right? It's a big phase 3, right? It's steeper, it's quicker, and occurs very early, right? It's big. That makes this T wave tall. It's bigger than normal. It's steeper and quicker and rapid. That makes the duration shorter, right? So why it is phase 3 is occurring sooner and at steeper rate, and even bigger compared to normal actually. That makes the T wave actually tall, because the phase 3 is so bigger now and occurs earlier. That because phase 2 is smaller now. Phase 3 starts early. It's very steep down, and is bigger than normal. Why? That makes the T bigger. I mean peak T wave and shorter T wave, peak T wave. Because T wave represents ventricular repolarization, right? That represents electrically ventricular repolarization. So why it happened that way? What channel activity are increased in phase 3 and why?
Repolarization.
Yeah, it is increased, but why the repol is increased? Why it is bigger and why it is increased? Earlier, why it becomes earlier? Why it is steeper? Why it is bigger?
Well, because we get more potassium outside of the cell.
Why? There's already high potassium outside the cell in hyperkalemia. Why I want to put more potassium? This is the controversial. I mean, there is a reason why. I will explain that, and I did explain that earlier. But people understand that the patient is already having hyperkalemia. Why want to push more potassium out from ICF to ECF in phase 3? Patient is already hyperkalemic. That will make it more worse, which is true. That's the cause of death in this patient. Patient dies because of that. But why our body reacts that way? Why our compensatory response occurs at the level of ionic channel that way? That is that will kill us. That is fatal. That is life. That makes this thing more complicated. Why phase 3 is more stronger, bigger, and quicker and earlier, despite there is a high level of potassium outside. I thought we discussed it, and you all were able to answer it. Why there is increased outward potassium current in phase 3, despite there is a hyperkalemia? So what has happened before phase 3 in phase 0 and phase 2? What has happened in phase 0 and phase 2? In phase 3, you are recruiting more voltage-dependent potassium channel. Okay, which is called IKR channel. Specifically, it's called IKR channel that will actually increase the outward potassium current. You are recruiting that more and more. You are expressing that more and more in hyperkalemia in phase 3. What is the reason why it gets more recruited? We don't want that. It's actually more worse. It will make these things more worse. Why we recruit that more in phase 3? What is the stimulus for that? That will open up more potassium channel in phase 3.
But the potassium has the leak channels too. That's the reason.
Well, leak channels doesn't play any. Remember that, please. It's a good thing you brought it up. Leak channels doesn't have any role in phase 0, 1, 2, and 3. Leak channels are mainly, I mean, they are open, but they don't have any role in contributing any of these phase except phase 4. Phase 4 is also because of the leak potassium channel, and there's another channel called IK1. I don't want to get into that. That will be too much beyond the scope of your class. It's called delayed inward rectifier potassium channel. It's called IK1. Don't worry about that. Which is responsible for potassium leaking outside. So it's not only that's a major driver, IK1, and other is leak potassium channel. That together will create a phase 4 here, RMP. RMP is because of the IK1 potassium channel and leak potassium channel together. They are responsible for phase 4, creating RMP. We talk about that 10 times, so you all know that. But my question is that why phase 0 and phase 2 will impact phase 3? How that will impact phase 3? Why phase 3 is so quickly happening and happening big? It's more bigger than normal. That makes the T wave taller and happening very quickly and faster rate and steeper rate. That will make the T wave duration smaller, lesser. So why phase 3 happens quickly and bigger?
Because potassium conductance increases.
Yes, very good. I agree exactly. But why it is increased? That's my point. Why you recruit more potassium channel, IKR channel? That's my question. We don't want. Okay, Sadaf, you already have high potassium outside? Yes or no? Tell me.
Yeah.
Okay, then why body will try to push more potassium outside, making it more worse?
Cars, I don't know. The electrical gradient, I don't know.
Return it to its equilibrium potential?
Say that again, Erin.
To return it to its equilibrium potential.
I love that. Why? We are there. Why? You talk about that. Very good. Why?
Well, when there's a lot of potassium now,
No, I agree. But what is the trigger? What is the stimulus? I agree that you are far from potassium equilibrium potential. That's one of the driving that will increase the conductor. That will increase the driving force on potassium to get closer to get to RMP quickly. I agree with you. You are correct. But why that happened that way? First of all, why we reached at that level, at that stage that you want to quickly reach to phase 4? Why I want to make phase 3 that quick and bigger and sharper, steeper to reach to phase 4 quickly? What is the trigger for that?
That's my question. Negative membrane potential, less negative membrane, less negative membrane.
Exactly. But why it is less negative?
Because we have more potassium outside, so we can't even go outside.
Yeah, I agree. But why it is less? Why it is less? Yes, Mrs. Abraham. Hello?
I'm a pass.
Okay.
Yeah.
You already have a high potassium inside, agree, Sadaf? Because there is no gradient for potassium to go.
Yeah.
Right? So inside is positive now, right?
Yes.
Right? You make inside positive in hyperkalemia.
Yeah.
Agree? Or less negative, depolarized.
Yeah.
Right? So that inside positive or cell membrane, since you make the cell membrane depolarized, it's a trigger for potassium to open, the channels to open.
Yeah.
Simple. Right? And then what else? Why that opens? In order to bring that membrane potential towards its own RMP or equilibrium potential, as Erin said earlier. But what is the trigger? The trigger is the cell membrane gets depolarized because the potassium accumulates inside the cell. Right? Why RMP goes up? Why RMP is going up here? Tell me. In hyperkalemia. Why RMP is shifted towards the threshold potential?
The ion balance has changed so that there is a lesser driving force, and since the leak channels go with the gradient, the gradient reduces the amount of potassium
Right.
inside, so that's why it's more positive.
Right. So there is more potassium inside, right? Right? Say yes or no. Okay. Potassium is cation, right?
Correct.
Okay. So it will make inside less negative or positive, right?
You are more positive, yes.
Yes. It will depolarize the cell membrane, yes or no?
Correct.
Right. So what is the effect of when the cell membrane is depolarized? What is the effect of that on the potassium channel?
Reduce potassium gradient.
Hypersensitivity.
No, I'm talking about potassium. When you depolarize the cell membrane, how that will impact the level of how will that will impact the potassium channel recruitment?
It would increase.
Exactly. There you go. Period. Because you depolarize the cell membrane, thank God. You depolarize the cell membrane prematurely because the potassium accumulates inside the cell, and that depolarization is a stimulus trigger that will recruit more potassium channel in phase 2 and in phase 3. Both. In phase 2 and phase 3, both. That's why phase 2 is more smaller and it will actually repolarize very quickly. It's not plateau now because more outward current potassium is increased in phase 2 and less inward calcium current. That will make the phase 2 shorter. Okay. So what would happen to the ST segment if you make the phase 2 smaller? Is Dhruv here? I don't know. Okay. Maybe he left. What would happen to this is all very important for the exam as I'm discussing it. Okay. Again and again. If you make the phase 2 smaller, which is P2, right, in hyperkalemia, what would happen to the ST segment? ST segment is from here to here, S to here, right? ST segment, right? S and T here, T, ST segment. So what would happen to the ST segment?
It gets shorter.
Very good. Why?
Because it's repolarizing faster.
Yes, exactly. Beautiful. Beautiful. Outstanding. What is ST segment representing in EKG?
Repolarization.
Very good. Starting, right? It will start, right? And the whole T wave until you finish the T wave, right? Very good. So ST segment will be shorter, right? On EKG. Beautiful. What would happen to the PR interval again? PR interval. What is PR interval?
Time from the arterial depolarization.
Atrial.
Yeah, arterial.
Atrial, beginning of atrial to beginning of?
Yeah, to ventricular.
R, right? R, PR interval, right?
Yes.
Right. So what would happen to PR interval? Be prolonged, very good. Why it will prolong? Atria depolarized slowly now, right? P is atrial depolarized. QRS is ventricular depolarized. They both will depolarize slowly. Agree? Phase 0 will be steeper, right? Less steeper. We just talk about that. So what would happen to PR interval?
Is it prolonged because of low excitability?
Exactly. Good. And what would happen to the heart rate because of that?
It will go down.
Very good. Slower heart rate, right? It takes more time to complete the cycle. So that's it. That's a concept here. You guys are expert. You guys are really good at that. Now I can see that. It's good to review. No, I mean, I'm serious about that, Jasmine. You guys are really good at that. Now I can see that you guys understood all the concepts. That was the goal of this session. To review everything what we discussed yesterday or the best possible with this case. So make sure you review all these things again one more time. And if you have any questions, reach out to me. And if you have any questions, I can stay back. But I will not take that many questions. But I think we discussed everything multiple times. So you should be good. You all were able to answer all the questions now. So